think a lot more lines because I kind of called them out on it.
Oh, but I mean, we can still start our levo even if the central line's not in
Yes.
ED, get
Yes.
going. And then
Get it going. Don't let somebody sit hypotensive. Don't want, hypotension is bad.
You're saying not to give like 30 cc's per kilo if they're not hypertensive.
You don't have to. If they're not hypotensive and their lactate's not greater than 4, you don't have to give the fluids, or greater than 2. However, I would err on the side of giving the fluids in most cases. So, yeah, because if they're not hypotensive or they're not tachycardic, they're not, yeah. There's usually, the other thing is that if they're acidotic, that's probably going to be from lactate. 10% of patients who have severe sepsis, even septic shock, will have normal lactate. I can't really explain it, but yeah. So just because their lactate's not elevated doesn't mean they don't have septic shock. So.
There's also love around vitamin C.
Oh God!
Study
Killing me,
trying to replicate. Do you think it's like just the next Cyrus? Like,
I don't know.
You
That's
don't
why
know?
we haven't instituted it. So there is a randomized trial going on, a multi-center randomized trial that's going on now.
you need to be more
Yeah.
reliable than the initial
Yes.
study done.
Yeah, the initial study. Who the first author on that study is also somebody I trained with. So, and I've talked to him about it, and he said don't change anything yet. So yeah, so yeah, it's interesting, and a lot of people have jumped on the bandwagon for that, but there's a lot of issues with that study. It was pretty biased.
One other question, there was a slide about other support therapies, one being bicarb. Do you have like a certain threshold? Yes, this is time for bicarb, or is it just case to case looking here?
So bicarb, usually if you look at the literature, you need to have, you're supposed to be using bicarb. You can use bicarb. It's not actually a recommendation until their pH is less than 7.15. Okay, it's never, and bicarb has never been shown to improve outcomes. Okay, so, I think that I have a little bit of bias towards it. If they're really acidotic, I'm probably going to give it to them. But yeah, there's nothing that says that you have to give it, should give it, because there's really no data to support it. So.
It just seems to be like a physician specific
Yeah,
order.
that's where the art of medicine comes in, because we don't have the right answer there. So, yeah.
I was just going to add to your comment about putting a pressor through peripheral line, just making sure that, yes, absolutely, we do want to do that. Just make sure you check that line every 15 minutes. That's the standard of care until you
Yeah.
get a central. Just making sure. We do it in the ED all the time,
Yeah.
but I always remind our nurses, check that line every 15 minutes. Make
Do
sure
not
it's
want it to
still going
infiltrate.
through. Yeah.
That is
And then
bad.
advocate for central right away, which
Our
our
docs
docs
know.
know. Just
Yeah,
Jesse's on.
yeah.
When do you find ordering a procalcitonin beneficial for monitoring sepsis? We don't see it ordered as much as we thought.
Yeah, I don't know. I mean, it matters on if you're asking the rep for the procalcitonin or not. So, we don't have a huge issue with antibiotics being in the ICU. We're supposed to be looking at antibiotic usage daily, and that's what Zach does. And so I think we tend to stop the antibiotics on a regular basis before we even would get the procalcitonin. But if somebody's sick, it's hard to stop the antibiotics, even if the procalcitonin is normal. If it goes down, but they're still really sick. So I've struggled with it in the ICU on how to use it. I think procalcitonin is pretty good to use on the floor for a patient coming in with pneumonia. And that's the only place it's been shown to be effective is in pneumonia, right? So it has to be pneumonia. It's not sepsis from UTI. It's not sepsis from abdominal. It has to be just a pneumonia. And most of the time, a lot of times in the ICU, we don't know what the cause is up front. So, but if they come in with a clear pneumonia and their procalcitonin's elevated, and then you get the secondary procalcitonin in 3 or 4 days, and it's low, you can probably stop antibiotics. But most pneumonias can be treated with an antibiotic course of 5 days. So we should be putting stop dates on the antibiotics that are appropriate for that patient. So if you have a problem with prolonged antibiotic usage, procalcitonin can be useful.
Okay.
But in the ICU, I struggle with it. And sometimes, I mean, I see it all the time from hospitalists, but none of us have figured out how to use it in the ICU. The studies weren't really geared towards us.
In our facility, do you see a lot of prolonged use of antibiotics inappropriate?
On the floor, yeah.
Is there any way to control that?
Put
better?
stop dates in. Yeah, look at it every day, you know. That's the tough part, is that, especially the way we transition from doc to doc
Right,
sometimes.
like you think like pharmacy should own that, pharmacists on the floor should
Well, I
own
love
that,
how
or-
other people own it and stuff, yeah, no, but Zach does, Zach
I
will
know
say.
Zach does in ICU,
Yeah.
but that's why.
And the pharmacists on the floor do too.
On the floors that round, they do talk to all the docs,
Yeah.
but they now, with our big transition to getting patients out at an earlier time, they don't have a chance to round as much, so like Community North isn't rounding anymore,
Yeah,
which you lose that opportunity. So
Yeah.
then the pharmacists are going to individual hospitalists because they don't really have any hospitals in Community North anymore, so. They are, it's just not as smooth as it used to be with like the actual rounding room to room units. Surgical floors are kind of hard because you're trying to capture like a PA or somebody like that, so. But they do have this antibiotic timeout that they do communicate every day, so even if you're the next person on shift, they have an antibiotic timeout, CI that we do. It's like, is this appropriate, can we de-escalate, can we go oral?
no, I think antibiotic usage is a huge problem. And so we shouldn't be allowed to put antibiotics, order antibiotics without a stop date. That's, I know. I did, previously where I worked, we had a 5-day limit on all antibiotics that we ordered. So if you wanted it more than 5 days, you had to reorder. So that takes care of the whole issue of procalcitonin, because if they're better in 5 days, you're not going to continue the antibiotic. So you don't need a procalcitonin. So, but a lot of our ICU patients would need it for longer than that.
So then do you see issue with the calling out and really noticing that they're not being covered anymore?
Well, you should be looking at it every day. But I can tell you that for most things in the hospital that we treat, 5 days is usually enough. I think it's recommended for some of the more complex stuff we see in the ICU, 7 to 10 days. But there are trials out there that look at 5 days and they do just fine. So usually I kind of err between that 7 and 10 days for a lot of the more complicated stuff that we get. So.
I thought I saw something, we're gonna start using angiotensin too, or have it available.
Oh yeah, I didn't really talk about that. We're working on that, yeah.
Okay, and that's gonna be after vasopressin, right?
It'd be the third pressor
Yeah,
in certain situations. So
that's still kind of far off.
no, it's like probably in the next month or two.
Oh, sweet.
Yeah. So, but we're gonna get more. We're gonna have a pathway for using it.
Okay.
And we gotta get everybody educated before we start putting it out there. It's definitely something we don't want to use on everybody. It's expensive. So. It's
Oh,
gonna-
and for those of you in ED, it is restricted to intensivists.
Yeah.
So
Yeah.
by the time, we won't be adding a third pressor.
It's a
It'll be
third,
an
yeah,
ICU.
they should not be in the ED and need a third pressor. So hopefully we have enough beds, because that would be a problem.
that would be a
So yeah, it's restricted to us. We didn't want cardiology, we didn't want it just to be out there for anybody to use. So,
Well, thanks, guys. Thanks, Dr. Scoggins.
yeah, thanks.
You.
Thank you.